From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
I'm Dr. Kristin Walter, Associate Editor at JAMA and a pulmonary critical care physician. I'm joined today by Dr. Nicole Ruopp, who is an Assistant Professor of Medicine at Tufts Medical Center and Tufts University School of Medicine. We will be discussing the article she wrote along with Dr. Barbara Cockrell, a pulmonologist at Brigham and Women's Hospital in Boston and an associate professor at Harvard Medical School. Their article is entitled Pulmonary Arterial Hypertension Classification, Diagnosis, and Treatment, a Review. This article was published in the April 12th issue of JAMA. Thank you for joining us, Dr. Ruopp.
Thank you for having me.
So to start off, just discussing basic terminology, can you define pulmonary hypertension for us?
Yeah, pulmonary hypertension hemodynamically is defined as a mean pulmonary artery pressure of greater than 20 millimeters of mercury. Pulmonary hypertension is divided into 5 subgroups, one of which is pulmonary arterial hypertension. And the hemodynamic definition of this is a mean pulmonary artery pressure of greater than 20 millimeters of mercury, a pulmonary artery wedge pressure of less than or equal to 15 millimeters of mercury, and a pulmonary vascular resistance of greater than or equal to 3 Wood units.
Although the pathophysiology is not totally clear, can you discuss the vascular pathology that is seen with pulmonary arterial hypertension?
Yeah, so the hallmarks of pulmonary arterial hypertension pathophysiology is really centered on this idea of vascular remodeling. So within the arteries, we see medial and intimal remodeling. We see the development of plexiform lesions, which are really these small, irregular vascular channels that are separated by fibrous tissue. And we also see fragmentation of the elastic lamina. Over time, this remodeling actually causes an increase in the resistance in the arteries and raises the pulmonary vascular resistance. This rise in pulmonary vascular resistance leads to an increase in mean pulmonary arterial artery pressure. And over time, those things in conjunction can cause strain on the right side of the heart and lead to the RV failure that we see in pulmonary hypertension. Vasoconstriction also certainly plays a role in the pathophysiology of pulmonary arterial hypertension. Unfortunately, we don't really understand whether this vasoconstriction is an inciting event or a complication of the vascular remodeling that we see. However, many of our treatments are targeted towards this vasoconstriction as we treat pulmonary arterial hypertension with pulmonary vasodilators.
And how common is pulmonary arterial hypertension?
So it's really not common at all. Pulmonary arterial hypertension is an uncommon disease. The prevalence of it really varies depending on which registries you're looking at. As a rare disease, we rely predominantly on registry-based studies. So if you look in the United States at the largest registry we have here, the REVEAL registry, you see an incidence of around 2 cases per million per year, with a prevalence of around 10.6 cases per 1 million adults. If you look in, say, Europe at the French registry, you see an incidence and a prevalence that are somewhat similar, 2.4 cases per million per year for an incidence there, and the prevalence is around 15 cases per 1 million adults.
And which patient characteristics, such as age or sex, are associated with pulmonary arterial hypertension?
So that's a really interesting question, mostly as it's changed over time. So if you look at some of our early registries, the earliest of which was the National Institute of Health Registry in the 1980s, the predominant age of a patient with pulmonary hypertension, the mean age, was around 35. And it was nearly a 4-to-1 female to male ratio. Over time, that has evolved. And so modern registries have somewhat of a different picture. And if you look in the US-based REVEAL registry, our mean age for patients with pulmonary arterial hypertension now is around 50, so they're older. And they also, although still female predominant, are not as female predominant as in the past. So we now center around a 1.7, nearly a 2-to-1 female to male ratio. And we're really unclear on exactly what the underlying etiology is for this change. We aren't sure if it really just represents a true temporal change in the demographic of patients with pulmonary arterial hypertension, or if, more importantly, it probably represents an increase in awareness of the disease and an increase in diagnosis.
And can you describe some typical symptoms associated with pulmonary arterial hypertension?
Yes. So pulmonary arterial hypertension has an insidious onset, and most commonly, the symptoms that accompany it are very subtle. It starts with dyspnea on exertion and can present with fatigue as well. As the pressures rise in the pulmonary vasculature and the right heart comes under increasing strain, you can start to see signs and symptoms of heart failure. So you can see lower extremity edema and lightheadedness and pre-syncope. Ultimately, if the right heart is really starting to fail, patients can present with true syncope.
And what are important components of the diagnostic evaluation of patients with possible pulmonary arterial hypertension?
In patients who you suspect could have pulmonary arterial hypertension, it's good to start with the basics. So basic labs, including a complete blood count, chemistries, liver function test, a B natriuretic peptide or NT-proBNP, thyroid studies, and an EKG. In patients who you really are suspecting could have pulmonary hypertension, pulmonary function tests, and an echocardiogram to screen for elevated pulmonary artery pressures and right-sided heart dysfunction are also indicated. If those things support the diagnosis of pulmonary hypertension, then a right heart catheterization is indicated to truly diagnose pulmonary arterial hypertension. It cannot be diagnosed without a right heart catheterization. The right heart catheterization also serves to help us group the pulmonary hypertension and to help us understand the severity of it. So once you've confirmed the diagnosis of pulmonary hypertension on right heart catheterization, you need to rule out that it is secondary to chronic clot or chronic thromboembolic pulmonary hypertension with a CT pulmonary angiogram or a VQ scan.
Pulmonary arterial hypertension is categorized into subgroups based upon pathology and etiology. Can you start by discussing idiopathic pulmonary arterial hypertension and what % of patients are thought to have idiopathic pulmonary arterial hypertension?
Yeah. So idiopathic pulmonary arterial hypertension is diagnosed in patients who meet the hemodynamic criteria for pulmonary arterial hypertension, but aren't found to have an underlying etiology to explain it. So they don't have a condition that would predispose them to pulmonary arterial hypertension, such as connective tissue disease or HIV. And as a result, they're diagnosed with idiopathic disease. The percentage of patients who are diagnosed with idiopathic pulmonary arterial hypertension varies depending on the registry you look at, but ranges anywhere from 39 to 46%, looking at US and French-based registries.
The next group is group 1-2 is heritable pulmonary arterial hypertension. Can you discuss the most common gene mutation found in this condition and its pattern of inheritance?
So heritable pulmonary arterial hypertension is pulmonary hypertension that is associated with an underlying genetic mutation. And we've found over 15 of these mutations thus far in hereditary pulmonary arterial hypertension. The most common mutation is a mutation in something called the bone morphogenic protein receptor 2 gene, which accounts for over 75% of heritable pulmonary arterial hypertension. BMPR2 mutations are inherited in an autosomal dominant, incomplete penetrance fashion, meaning you can have the mutation, but you may or may not develop disease. Interestingly, when we look at idiopathic pulmonary arterial hypertension patients, so patients in whom an underlying etiology causing their pulmonary arterial hypertension have not been found, we find that approximately 25% of those have been diagnosed with or can be diagnosed with BMPR2 gene mutations, really underscoring how important it is to have genetic testing in these patients.
And how does the disease trajectory compare between those who have idiopathic pulmonary arterial hypertension and those with heritable pulmonary arterial hypertension?
That's a really great question. So those with heritable pulmonary arterial hypertension, more specifically those with BMPR2 gene mutations, tend to present earlier. So they present somewhere in the range of their late 30s as compared to their mid 40s with idiopathic disease. They also tend to present with more severe hemodynamics at diagnosis, and they tend to be less responsive to therapy and therefore have worse prognoses.
The next group is drug and toxin-induced pulmonary arterial hypertension. Can you discuss specific drugs or toxins that are most common causes of this condition?
Yeah, so we have found several drugs and toxins that are known to be associated with the development of pulmonary arterial hypertension. The previous most significant one was a compound called fenfluramine. Most recently, methamphetamine and dasatinib have played larger roles. Dasatinib is a targeted cancer tyrosine kinase inhibitor that is used to treat cancer. Pulmonary arterial hypertension associated with dasatinib is uncommon, with an incidence rate of around 0.45%, compared to around 10 to 15 cases per 1 million adult inhabitants in patients who aren't treated with dasatinib. Methamphetamine is also associated with the development of pulmonary arterial hypertension, and patients who use methamphetamine have higher rates of pulmonary arterial hypertension related hospitalization than non-meth users. Compared to idiopathic pulmonary arterial hypertension patients, patients who are diagnosed with methamphetamine associated pulmonary arterial hypertension tend to present with more severe hemodynamics at diagnosis and tend to progress more rapidly.
And with dasatinib-associated pulmonary arterial hypertension, does it improve with discontinuation of the drug?
Yes, so this is really an interesting point about dasatinib-associated pulmonary arterial hypertension. So what we know in this situation is that you treat the pulmonary arterial hypertension, at least initially, with discontinuing the drug. And in that setting, according to pharmaceutical vigilance data, about 94% of dasatinib-associated pulmonary arterial hypertension will resolve in this setting.
Interesting. The next category of pulmonary arterial hypertension is those associated with systemic diseases. The first is connective tissue disease associated with pulmonary arterial hypertension. Can you discuss which conditions are in this subgroup and which connective tissue disease is most commonly associated with pulmonary arterial hypertension?
Yes, so connective tissue disease associated pulmonary arterial hypertension is the second most common subgroup of pulmonary arterial hypertension. It's associated with diseases such as scleroderma, systemic lupus erythematosus, mixed connective tissue disease, rheumatoid arthritis, and Sjogren's. Of these, scleroderma is the most common cause of CTD associated or connective tissue disease associated pulmonary arterial hypertension, with a prevalence of around 8 to 14%. Additionally, scleroderma associated pulmonary arterial hypertension has a worse prognosis than other connective tissue diseases, such as lupus or mixed connective tissue disease, who also develop pulmonary arterial hypertension.
Next is HIV-associated pulmonary arterial hypertension. How common is this condition, and which patients with HIV are recommended to undergo echocardiogram to assess for pulmonary hypertension?
Yeah, so pulmonary arterial hypertension is a potential complication of HIV, and it's uncommon. It has a prevalence of around 0.46%, compared to around 10 to 15 cases per million adults in patients who aren't HIV positive. The World Symposium on Pulmonary Hypertension recommends screening echoes in all patients with HIV who also have dyspnea, or in patients with HIV and additional pulmonary hypertension risk factors, such as female sex, those using intravenous drugs or with a history of intravenous drug use, those with a history of cocaine use, or hepatitis C infections.
The next group is portal hypertension associated pulmonary artery hypertension. How common is portal pulmonary hypertension, and how does it typically respond if the patients undergo a liver transplant?
So, portal pulmonary hypertension develops in the setting of portal hypertension, either with or without cirrhosis. In patients with cirrhosis who are undergoing an evaluation for a liver transplant and are found to have portopulmonary hypertension, slightly less than half have resolution with liver transplant, and slightly over half continue to require pulmonary vasodilators post-transplant.
The next two categories are congenital heart disease and schistosomiasis associated pulmonary arterial hypertension, which is clearly not a common condition in the US, but affects many people around the world in countries that have endemic schistosomiasis. Can you briefly discuss how commonly patients with schistosomiasis liver disease develop pulmonary arterial hypertension?
Schistosomiasis-associated pulmonary arterial hypertension is a leading cause of pulmonary arterial hypertension in endemic countries. And because of the large proportion of schistosomiasis in many of these countries, it's felt to be potentially the largest cause worldwide. Of those patients with severe schistosomiasis liver disease, around 5 to 8% ultimately will develop schistosomiasis-associated pulmonary arterial hypertension.
And group 1.5 is a relatively new category. It's pulmonary arterial hypertension in long-term responders to calcium channel blockers. Can you discuss this group?
Yeah, so this is a category that was first recognized in 2018 at the World Symposium for Pulmonary Hypertension. And it really is meant to demarcate these patients who seem to have a long-term response to calcium channel blockers. So we define that as a patient who has a positive vasoreactivity challenge in the cath lab to inhaled nitric oxide, and then demonstrates an improvement to functional class 1 or 2, as well as stable or improved hemodynamics at 1 year on calcium channel blocker monotherapy alone. Now, an important caveat to this group is that vasodilator testing should only be performed in patients who are diagnosed with idiopathic pulmonary arterial hypertension, hereditary pulmonary arterial hypertension, or drug and toxin associated pulmonary arterial hypertension, as these are the only subset of patients who have been found to demonstrate prolonged calcium channel blocker responsiveness.
So, moving on to treatment of pulmonary arterial hypertension, your article mentions the importance of referring patients to a pulmonary hypertension specialty center. Can you discuss the benefits of treatment at a pulmonary hypertension center?
Certainly. So, patients with pulmonary arterial hypertension are complex, with really complex pathophysiology, and they require a multidisciplinary approach to treatment. We have observational data that shows that treatment at specialty centers in these complex patients are associated with decreased hospitalizations as well as increased survival. But there are additional benefits of being treated at a specialty PH center. Patients treated at specialty PH centers also have access to clinical trial enrollment as well as support groups, which can be very helpful for their course.
And when are calcium channel blockers recommended for pulmonary arterial hypertension, and when should they be avoided?
So, of the patients who meet criteria for vasodilator testing, those, as we've said, with diagnosis of idiopathic pulmonary arterial hypertension, hereditary pulmonary arterial hypertension, or drug and toxin-induced pulmonary arterial hypertension, who are found to have a vasodilator response, calcium channel blockers can be considered in these patients. The caveat to this is if there is concern that these patients are high risk by risk assessment, the practitioner may opt to treat them with combination pulmonary vasodilator therapy. Calcium channel blockers should be avoided in patients who don't meet these criteria, as they can cause hypotension and syncope.
And the primary classes of medications used in pulmonary arterial hypertension treatment include phosphodiesterase 5 inhibitors, soluble guanylate cyclase stimulators, and endothelin receptor antagonists. Can you discuss how effective these drugs are and whether they should be given as a single agent or in combination?
Yeah, so previously, our treatment regimens in pulmonary arterial hypertension centered on monotherapy-based regimens with these drug classes. We've since discovered that regimens involving or targeting multiple different biologic pathways simultaneously from each of these drug classes has resulted in improved outcomes, namely improved time to clinical worsening, which includes decreased mortality and morbidity. We now base or center our regimens on this idea of targeting multiple different biologic pathways simultaneously. And the efficacy of these combination regimens really depends on the individual agents within the regimens in combination rather than on individual agents themselves.
Is there a set regimen that you start with?
For patients who are on risk assessment deemed to be low to intermediate risk, the typical procedure is to start them on a combination therapy-based regimen, of which the data is best for the combinations of ambrisentan and tadalafil, or macitentan with a PDE5 inhibitor, either sildenafil or tadalafil, or the combination of selexipag with an ERA or a PDE5 and or a PDE5 inhibitor.
And can you discuss adjunctive therapies for pulmonary arterial hypertension?
Diuretics can be very helpful in pulmonary arterial hypertension. As the right ventricular failure progresses, diuretics can help offload and decongest the right ventricle. Aldosterone antagonists can also be helpful for such as spironolactone, for neurohormonal blockade, and to help augment diuresis and prevent hypokalemia. Oxygen is also an important adjunct for patients who are noted to have a PaO2 of less than 60. Supplemental oxygen can be initiated to help improve oxygenation.
And can you discuss the effect of pregnancy on patients with pulmonary arterial hypertension?
Yes. So in the pregnant state, cardiac output and circulating blood volume increase. These can be challenging for the patient with pulmonary arterial hypertension to tolerate, especially as their right ventricle can be under significant strain already. And these pregnancy-associated changes can further challenge the system. In this setting, patients who have pulmonary arterial hypertension who are pregnant are at higher risk for RV failure and death, with a maternal mortality that can range anywhere from 13 to 16%.
Is there anything we haven't discussed about pulmonary arterial hypertension that you'd like to mention to our JAMA audience?
Yes. Pulmonary arterial hypertension is an uncommon disease, and a high index of suspicion is required for diagnosis. And we see this in that there's often a delay in diagnosis in our patients. In fact, in Reveal, just over 20% had a delay of over 2 years for diagnosis. We see this most commonly in patients who are young, who have concomitant respiratory disorders such as asthma, and that may deflect from a more formal pulmonary hypertension workup or a higher suspicion for pulmonary arterial hypertension. So I would just encourage everyone to have a high index of suspicion in patients who have risk factors for pulmonary arterial hypertension.
That was Dr. Nicole Ruopp, Assistant Professor of Medicine at Tufts Medical Center and Tufts University School of Medicine. Thank you so much for sharing your thoughts about this interesting and important topic. This is Dr. Kristin Walter. This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Jesse McQuarters, Shelley Steffens, Lisa Harden, Audrey Foreman, and Mary Lynn Ferkaluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.